Okay, let's unpack this. Today we're going to talk about a topic that, frankly, suffers from a massive PR problem.
That's putting it mildly.
It's a part of the human body that most of us, we spend our entire lives trying to ignore or hide or just pretend doesn't exist until it absolutely forces us to pay attention.
Right, until it screams for attention.
Exactly. So we're diving into the surgical management of the rectum and anal canal. Now, before you tune out, I want you to know the source material we're working with today is not. It's not your standard scary WebMD page.
No, not at all.
We're working with a high-yield, exam-oriented surgical review. It's designed for medical students and residence people prepping for the USMLE or the NEET PG. This is the tactical playbook surgeons use.
That's right. And while the public might see this as, a taboo subject, for a surgeon, this region is incredibly high-stakes real estate. The anatomy here is, well, it's unforgiving.
Unforgiving how?
We're talking about a place where a difference of millimeters defines the difference between a minor office-based procedure and a life-altering disability. Millimeters.
And that is exactly the mission for this deep dive. We want to bypass the embarrassment and really look at the engineering of it all.
The logic.
The logic of the anatomy. Because as I was reading through these protocols, what struck me is how binary the decision-making is. It seems like everything hinges on specific geographic borders. It's like a map with very strict zoning laws.
It really is. In this part of the body, anatomy is destiny. If there's one central theme we're going to explore today, it's how a single, invisible line inside the body dictates everything.
Everything.
Everything. It dictates whether you feel excruciating pain or absolutely nothing at all. It dictates how cancer spreads. And ultimately, it dictates whether a surgeon cuts you open or just prescribes you a cream.
That's fascinating. And the hook here, the immediate relevance, is that these issues are incredibly common. Bleeding, pain, altered habit.
Oh, almost everyone deals with this or knows someone who does.
But the difference between, say, a nuisance like hemorrhoids and a catastrophe like cancer is often invisible to the patient.
Exactly. And that's the danger. The body has a language. But in the pelvis, the signals can be counterintuitive. Often the most dangerous conditions are actually the quietest ones.
The quiet ones. Okay, so we need to learn how to decode those signals.
That's the goal.
Let's get into the landscape then. Let's map the territory. Segment 1, the geography of the pelvis. Walk us through the dimensions we're dealing with here.
Okay, so surgically speaking, we're dealing with two distinct tubes that happen to be connected, but they are very different beasts.
Okay.
First, you have the rectum. Think of this as the storage tank. It's about 12 to 15 centimeters long, extending down from the sigmoid colon. It just sits comfortably in the pelvic bowl.
12 to 15 centimeters. Got it. And below that?
Below that is the anal canal, much shorter, usually only about 4 centimeters long. This is the exit valve.
So storage tank and exit valve.
Right. Now, if you were just looking at a diagram, it looks like one continuous tube. But embryologically, and this is the key insight, they come from two completely different worlds.
Two different worlds.
Yeah.
What does that mean in terms of, development?
Well, the rectum comes from the hindgut. It's visceral tissue. It's part of your internal organs, just like your stomach. The anal canal, however, it comes from the proctodium, which is basically an invagination of the outside skin.
So the inside meets the outside.
Exactly. At some point in our development, the gut tube growing down meets the skin growing up. And where they meet, they crash into each other and they fuse.
And that crash site is the border we're talking about.
That is the border. It's a jagged, sawtooth line called the pectinate line, or more commonly, the dentate line.
The dentate line. Okay, this came up again and again in the source material. It's called the North Star for the surgeon. Why is this specific border so critical?
Because the rules of biology flip 180 degrees when you cross it. Let's look at above the line, the rectum side.
Okay.
The lining there is columnar epithelium, just like the rest of your intestines.
Yeah.
But the crucial factor, the thing that changes the patient's experience, is the wiring. The nerve supply above this line is autonomic.
Autonomic. Okay, let's break that down. That means visceral sensation, right? Not sharp pain.
Correct. Visceral nerves are, well, they're kind of blind to sharp pain. You can cut the rectal lining, you can burn it, you can biopsy it, and the patient won't feel a sharp pain.
Really?
They might feel pressure or distension, like a gas cramp, but they will not feel a cut. Evolutionarily, this makes a ton of sense.
How so?
You don't want to feel the scratching of waste material moving through your gut. You'd be in constant agony.
That makes perfect sense. But while it's convenient for digestion, I imagine it's a massive liability for diagnosis.
It is a huge liability. It means that pathology above the line like internal hemorrhoids or, more dangerously, early rectal cancer often presents as painless bleeding. A
Painless.
patient looks in the toilet bowl, sees bright red blood, but because they aren't hurting, they assume it's not serious. They think if it was cancer, it would hurt.
That is a terrifyingly dangerous assumption.
Huh.
So painless bleeding is actually the more ominous signal because the body isn't sounding the pain alarm.
Precisely. The silence is the trap. Now, contrast that with below the line.
Okay.
Cross that dentate line into the 4-centimeter anal canal. The lining changes to squamous epithelium. It is literally skin.
Like the skin on your hand.
Exactly.
Oh.
And the nerve supply becomes somatic, specifically via the pudendal nerve. This area has more nerve endings per square millimeter than almost anywhere else on the body.
So extreme sensitivity.
Exquisite sensitivity. Think about a paper cut on your fingertip versus one on your back. The finger hurts more because of nerve density. The anal canal is like the fingertip. A tiny tear there. An anal fissure feels like passing broken glass.
Wow.
So if a patient walks into my clinic clutching the chair, afraid to sit down, sweating from the anticipation of pain, I almost immediately know that pathology is below the dentate line.
It's basically a triage system built right into the nervous system. Painless usually means above. Painful usually means below.
That's the first filter. But there's a second filter that's even more critical for long-term survival: drainage. The lymphatic system also uses the dentate line as a watershed.
And this is all about how cancer spreads, right? Because cancer cells hitch a ride on the lymph fluid.
Exactly. Cancer moves through lymph nodes like a highway system. Above the line, in the rectum, the lymphatics follow the blood supply upward and inward.
Up and in.
They drain to the internal iliac nodes and the periaortic nodes. These are deep inside the pelvis and abdomen. You can't see them, and you can't feel them from the outside.
So a cancer should be spreading right there, and you'd have no external clue at all.
None. Now, below the line.
What happens there?
Below the line, the lymphatics drain outward to the superficial inguinal nodes. Those are the lymph nodes in your groin, right where your leg meets your torso.
So practically speaking, if a patient has anal cancer that's below the line, they might actually show up with a lump in their groin.
Exactly. A palpable lump in the groin can be the first sign of a cancer hiding in the anal canal. But a rectal cancer above the line won't show up there until it's very, very advanced.
This is why the surgeon has to know exactly where that line is.
It tells you where to hunt for the metastasis. If I'm treating a rectal cancer, I'm looking at MRI scans of the deep pelvis. If I'm treating anal cancer, I'm feeling the patient's groin.
That establishes a geography perfectly. It's like two different countries with different laws and different warning systems. I want to apply this now to the clinical encounter. The notes mention a diagnostic rule of thumb regarding symptoms. We touched on bleeding versus pain, but let's formalize it.
Sure. When we take a history from a patient, we're essentially acting as detectives, just decoding signals.
Okay.
So if the primary complaint is painless bleeding, my mental algorithm narrows down immediately. I'm not thinking about fissures. I'm thinking about two main suspects: internal hemorrhoids or rectal malignancy.
Okay, painless bleed equals hemorrhoids or cancer. And if the complaint is painful defecation...
And the algorithm switches to squamous territory below the line. We look for fissures, abscesses, or maybe a thrombosed external hemorrhoid. The pain tells us the location.
Okay, but here's where the source material puts up a giant flashing warning sign. It calls it the golden rule, or the exam trap. It says, bleeding per rectum is cancer until proven otherwise. That sounds incredibly severe.
It's the mantra that every single surgical resident has drilled into their head. And it's there to combat complacency.
Complacency.
You have to understand, hemorrhoids are incredibly common. Something like 50% of people will have symptomatic hemorrhoids at some point. But rectal cancer is also common, and terrifyingly, it's becoming more common in younger people.
Right. So the trap is just playing the odds, assuming it's the common thing.
Exactly. The trap is when a clinician sees a young, healthy-looking patient with painless bleeding and thinks, oh, it's probably just hemorrhoids, and hands them a cream without checking.
And in the meantime...
You can treat hemorrhoids for 6 months while a tumor grows from stage 1 to stage 3.
Wow, so the statistical probability says it's hemorrhoids, but the consequence of being wrong is catastrophic.
Exactly. In aviation, they have rules written in blood. This is a rule written in misdiagnoses. You must rule out malignancy before you treat for benign disease.
Even if you see hemorrhoids.
Even if you look in and you see the hemorrhoids, you have to look past them. You have to make sure nothing else is bleeding upstream. You can have hemorrhoids and cancer at the same time.
That is a very sobering thought. Let's dig into those usual suspects then. Let's start with hemorrhoids. They're probably the most misunderstood term in this space. People use it as a catch-all for any butt problem, but biologically, what's actually happening?
It's a great point. First off, everyone has hemorrhoidal tissue. It's normal anatomy. Everyone. They are vascular cushions, these pads of tissue with veins and arteries that actually help seal the anal canal so you don't leak gas or fluid. They're like the washers in a faucet.
So having them isn't the problem, it's when they fail.
Right. When the supporting tissue weakens, often from chronic straining, constipation, pregnancy, just gravity over time, these cushions slide down. They get engorged with blood. We grade internal hemorrhoids, the painless ones above the line, on a scale of 1 to 4 based on prolapse.
Prolapse meaning how far they fall out.
Yes. Think of it like a sliding door. Grade 1 bleeds, but it stays inside. The patient just sees blood.
Okay.
Grade 2 falls out when you push, like during a bowel movement, but it snaps back inside on its own afterward.
Okay. And grade 3?
Grade 3 falls out, but the snapback mechanism is breaking. It will go back in on its own. You have to manually push it back inside.
That sounds unpleasant.
It is. And grade 4 is the end of the line. It's stuck outside. It can't be reduced manually. It is permanently prolapsed.
And the treatment ladder matches the severity, I assume.
It does. Grade 1 and 2 are usually managed with what we call lifestyle modification. Fiber, fluids, stop looking at your phone on the toilet.
Wait, really? The phone thing?
Oh, absolutely. The toilet scroll is a major cause of hemorrhoids. That prolonged sitting creates a tourniquet effect around the veins.
I had no idea.
But for grade 2 and 3 that don't respond to fiber, we often use rubber band ligation.
I've heard of this. It sounds so crude, but effective. How does it work?
It's elegant in its simplicity. Through a scope, you place a tiny, tight rubber band around the base of the hemorrhoid. But here's the key. You place it above the dentate line.
Ah, because there are no pain fibers there.
Exactly. You're strangling the tissue, but the patient doesn't feel it. The band cuts off the blood supply. The tissue dies, ischemic necrosis, and it just falls off in a few days, leaving a scar. That scarred tissue then tightens up the wall, pulling everything back into place.
And if you accidentally did that below the line?
If you accidentally grab skin below the line, the patient would scream the hospital down. Location is everything.
Right. And for grade 4, the ones stuck outside?
That's when you need a hemorrhoidectomy. You surgically excise the tissue. It's effective, but unlike the banding, it's a very painful recovery because you are cutting near that sensitive somatic zone. We really try to avoid it if we can.
Let's pivot to the other common cause of misery, the anal fissure. The notes describe this as ischemic in nature. Now, I thought a fissure was just a tear from trauma, like a large stool.
It is initiated by trauma, yes.
Yeah.
A hard stool tears the lining, but the reason it doesn't heal and becomes chronic is ischemia, a lack of blood flow. And this is a fascinating bit of microanatomy that surgeons really geek out on.
Go on.
The posterior midline of the anal canal, the very back part, at the 6 o'clock position, has a relatively poor blood supply compared to the rest of the circle. It's what we call a watershed zone.
So it's already starving for oxygen, basically.
Exactly. So you get a tear there, it hurts. The sphincter muscle is designed to react to pain by contracting, by guarding. So the muscle goes into spasm,
Okay.
and when it spasms, it squeezes the blood vessels passing through it.
Which cuts off the blood supply even more.
Exactly. The spasm chokes the blood supply to the tear. So the tear can't heal because it has no blood. Because it can't heal, it keeps hurting. Because it keeps hurting, the muscle keeps spasming. It's a vicious cycle.
That explains why they can last for months. So the treatment isn't stitching the tear, it's relaxing the muscle.
Spot on. You have to break the cycle. We use ointments like nitroglycerin or diltiazem. These are medications that chemically relax the sphincter muscle.
And if that fails?
If that fails, we do a surgery called a lateral internal sphincterotomy. We essentially make a tiny nick in the internal sphincter muscle, off to the side.
You cut the muscle to save the skin. It feels counterintuitive.
It does. But by cutting just a few fibers, you relax the pressure, blood flow returns, and the fissure heals itself almost like magic. But there's a critical diagnostic nuance here we cannot miss. Location.
Right, the clock position of the tear.
90% of fissures are in that posterior midline because that's the anatomical weak spot. That's a normal fissure.
What if you see a tear on the side, a lateral fissure?
That is a massive red flag. A lateral fissure is not caused by mechanics. It's caused by pathology. It suggests the tissue itself is unhealthy. It screams Crohn's disease or HIV, tuberculosis, or even syphilis.
So if a surgeon sees a fissure on the side, they don't operate?
No, they investigate.
Okay.
If you operate on a Crohn's fissure, the wound will never heal. You'll make it so much worse. So simply looking at where the cut is can tell you if the patient might have a serious systemic autoimmune disease.
It's like Sherlock Holmes level deduction just by looking. Okay, moving deeper into the pathology, we encounter infection, abscesses, and fistulas. The source material calls these two sides of the same coin. Explain that relationship.
Think of it as a timeline of a single event. It all starts with the anal glands.
Okay.
We have these small glands inside the anal canal, right at the dentate line, that secrete mucus to lubricate things. Sometimes one of them gets clogged. It's like a pimple on your face, but deeper.
And bacteria get trapped.
Bacteria get trapped, they multiply, and it forms an abscess. That's the acute phase. You get pus, pressure, pain, fever. It's a closed-off infection.
And the rule for abscesses is straightforward, right?
Never let the sun set on pus. That's the surgical aphorism. Antibiotics can't penetrate a walled-off cavity of pus effectively. You must drain it surgically, immediate incision and drainage. You have to let the pressure out.
So you drain the abscess, the patient feels better, fever goes down, but then comes the chronic phase.
Right. In about 40 to 50% of cases, that drainage tract doesn't heal shut. It forms a persistent tunnel connecting the inside of the anus, where the gland started, to the skin outside where you drained it. That tunnel is the fistula in ano.
So now you have this tunnel that's bypassing the sphincter, and the patient complains of discharge.
Constant wetness, staining of undergarments, skin irritation. It's a hygiene nightmare and a quality of life disaster. Now, fixing this tunnel brings us to the biggest surgical dilemma in this entire field.
Which is the balance between cure and continence.
Exactly. To cure a fistula, the most surefire way is a procedure called a fistulotomy. You put a metal probe in the tunnel, and you just cut through the tissue over it, laying the tunnel open so it becomes a shallow groove that heals from the bottom up. Works 95% of the time.
I see the problem. If that tunnel passes through the sphincter muscle and you cut the tissue over it,
You're cutting the muscle that holds your stool in. You cure the fistula, but you give the patient fecal incontinence. And let me tell you, a patient will forgive a recurrence of a fistula. They will never forgive you for making them incontinent.
that's a Sophie's choice for the surgeon. So how do you decide?
We classify them using the Parks classification. But to put it simply, we call them low or high fistulas. A low fistula involves very little muscle. It's safe to cut. That gets a fistulotomy.
Okay.
A high fistula wraps through or above the critical muscles. That is the danger zone.
And for those high fistulas, since you can't just unzip the tunnel, what do you do?
We have to use what are called sphincter saving procedures. We might use something called a seton.
A seton? What is that?
It's basically a piece of surgical thread or a rubber loop that we pass through the fistula tract and tie in a circle. We leave it there.
And that does what?
It keeps the tract open to drain so it doesn't form another abscess and allows all the inflammation to settle down. Sometimes we'll tighten it slowly over weeks to cut through the muscle very, very gradually, allowing scar tissue to hold the muscle together behind it.
It sounds incredibly tedious.
It is. Or we use fibrin glue or plugs or complex flap surgeries.
Yeah.
The success rates are lower than simply cutting it, but the safety profile regarding continence is much, much higher. It really highlights how the surgeon is constantly negotiating with the anatomy. You're trying to fix the plumbing without breaking the valve.
I want to move to segment 5, which felt like the most heavy-hitting part of the review. Oncology. We have rectal cancer and anal canal cancer. To a layman, these sound like the same thing. Cancer in the bottom.
They could not be more different. They're different cell types, different behaviors, different spread patterns, and they have diametrically opposite treatments.
Let's start with rectal carcinoma. This is above the line.
Correct. This is adenocarcinoma glandular cancer. It arises from the polyps that we look for in colonoscopies. It presents with bleeding, weight loss, and a very specific haunting symptom called tenesmus.
Tenesmus. That's the feeling of needing to go, but nothing is happening.
Yes, it's a sensation of incomplete evacuation. The patient goes to the bathroom, they strain, they pass nothing, but they still feel full.
Why?
Because the tumor is occupying space in the rectum. The body interprets that bulk as stool, so it signals evacuate. But you can't evacuate a tumor.
That is a very distressing symptom. And for diagnosis, the notes emphasize the low-tech approach first.
The digital rectal exam, DRE. We live in an age of PET scans and MRIs, but a huge percentage of rectal cancers are within reach of a finger. It is inexcusable to miss a palpable tumor because you didn't do a manual exam. It's awkward, yes, but it saves lives.
But for staging, for figuring out the depth, we do turn to tech. The notes highlight MRI of the pelvis.
Yes. And specifically, MRI over CT scan. We need to see the layers. The rectum is wrapped in a fatty envelope called the mesorectum. We need to know if the tumor has punched through the rectal wall into that fat or into the nearby lymph nodes. MRI sees those soft tissue layers perfectly.
And that determines the treatment.
It determines if we can just do surgery straight away or if we need to give radiation first to shrink it.
And the surgery itself.
Surgery is the cornerstone for rectal cancer. We usually perform what's called a low anterior resection, or LAR. We cut out the section of rectum with the tumor and the mesorectum, that fatty envelope with the lymph nodes, and we sew the colon back down to the remaining anus. We restore the plumbing.
So the patient poops normally.
Hopefully.
Huh?
But what if the tumor is too low? What if it's right at the sphincter muscles?
And then you can't save the exit.
Exactly. We have to do an abdominoperineal resection, APR. We remove the rectum and the anus. We sew the bottom shut permanently. The patient lives with a permanent colostomy bag on their abdomen. It is a life-saving but life-altering operation.
That's the nuclear option. Now, contrast all of that with anal canal carcinoma. This is below the line.
Here's the plot twist. Anal cancer is squamous cell carcinoma. It's like skin cancer. It's often associated with HPV, the human papillomavirus, same virus that causes cervical cancer.
Right.
Decades ago, we used to treat this just like rectal cancer. We did the APR, giving everyone a colostomy bag.
But that changed.
It changed drastically. We discovered that this specific cell, type squamous cell, is incredibly sensitive to radiation and chemotherapy. It just melts away.
You don't cut.
We do not cut first. The standard of care is the Negro protocol. Chemotherapy, usually mitomycin and 5-FU, plus radiation. This combination completely destroys the tumor in the vast majority of cases.
That is amazing. You preserve the organ.
We save the sphincter, we save the function. We only operate if the chemoradiation fails or if the cancer comes back later. This is the exact opposite of rectal cancer, where surgery is the primary fix.
So if you confuse the two.
If you confuse the two and operate on an anal cancer first, you've done the patient a massive disservice by removing an organ that could have been saved.
That distinction is it's absolutely vital. It's a look before you leap scenario driven entirely by cell biology. Adeno means cut. Squamous means zap.
Precisely.
I want to briefly touch on the functional failures before we wrap up. Rectal prolapse. We talked about hemorrhoids prolapsing, but the rectum itself can turn inside out.
Yes. It's called procedentia. The entire full-thickness wall of the rectum intussuscepts, it telescopes out of the anus.
Visualizing that, it must be distinct from hemorrhoids.
Very distinct. Hemorrhoids look like distinct bunches of grapes, 3 separate piles. A prolapse looks like a continuous concentric cylinder of red tissue. It looks like a sock being turned inside out.
And who does this happen to?
The key demographic is elderly women. It's often due to pelvic floor laxity over decades, sometimes related to previous childbirths, coupled with chronic straining.
And finally, incontinence. We've mentioned it as a surgical risk, the surgeon's nightmare, but what causes it naturally?
Obstetric trauma is the leading cause. A difficult childbirth can tear the sphincter muscles. The woman might compensate for years because her muscles are strong and young, but as she ages and the muscles weaken, that old injury manifests as incontinence decades later.
That's heartbreaking.
It is. And the critical takeaway for the surgeon is that if a patient already has a weak sphincter, you have to treat their other problems, like fistulas or hemorrhoids, very, very conservatively. You don't want to be the one who tips them over the edge from weak to incontinent.
You have to treat the whole patient, not just the whole.
That's a good way to put it. It's a delicate ecosystem. You touch one thing, it affects the whole system.
Let's bring this all together. We have covered a massive amount of dense material. Let's synthesize this into the rapid review. The source material offers these key points to master this region. Let's run through them for the listener to lock it in.
Let's do it.
Okay, point 1, the dentate line.
The border control. Above is visceral, no pain, and drains to the pelvis. Below is somatic painful and drains to the groin. Know your location.
Point 2, the bleeding rule.
Painless bleeding. Think internal hemorrhoids or rectal cancer. Do not ignore it just because it doesn't hurt.
Point 3, the pain rule.
Painful defecation. Think below the line. Fissures, abscesses, thrombosed hemorrhoids. The pain localizes the lesion.
Point 4, the fissure location.
Posterior midline is ischemic and common. A fissure on the side, a lateral fissure, is suspicious for systemic disease like Crohn's or HIV.
Point 5, the abscess imperative.
Incision and drainage immediately. Antibiotics alone do not work on pus cavities. Get the pus out.
Point 6, the fistula trap.
High fistulas involve the sphincter. Do not cut the muscle. Use sphincter-saving techniques like setons to preserve continence.
Point 7, the rectal exam.
The finger is a diagnostic tool. Palpable tumors must not be missed. Do the DRE.
Point 8, staging.
MRI of the pelvis is the gold standard for rectal cancer depth. We need to see the layers.
Point 9, the oncology twist.
Rectal cancer equals surgery first. Anal cancer equals chemoradiation first. Don't cut anal cancer first.
And point 10, the golden safety net.
Bleeding per rectum is malignancy until proven otherwise. Never, ever assume it's just hemorrhoids. Prove it.
That's the cheat sheet. Looking back at this discussion, what stands out to me is how much information is encoded in the type of suffering. The body isn't just hurting, it's communicating coordinates.
That's a beautiful way to put it.
Hmm.
The patient's subjective experience, it hurts like glass, versus I just saw blood, maps directly to the embryology and the anatomy. If you listen to the story, the diagnosis is often 90% done before you even start the exam.
It brings a lot of logic to a very scary subject. Here's a final thought for our listeners to chew on. We live in a culture that tells us to ignore this part of our body, to flush and forget. But in this specific region, silence, the absence of pain, is often the most dangerous signal of all.
Absolutely. Pain forces action. You go to the doctor because you hurt. The absence of pain breeds complacency. That's why we miss rectal cancers. People wait.
So pay attention to the signals, even the quiet ones. Thank you for joining us on this deep dive. Hopefully we've made the taboo a little more technical, a little less squeamish, and a lot less terrifying.
Stay curious and listen to your body.
See you on the next one.